of West Bengal, the respiratory chapter of West Bengal Academy of Pediatrics. We had a good start last month in spite of the hurdles, and we have, a very interesting 1 hour ahead of us, where we are going to learn all about a single subject, which is empyema. And of course, everything is good when it starts with a case-based discussion. So I would invite all of you to stay on, glued on, and keep your question answer session ready for the very end, please. We will be doing the question answers. I think we will do it at the right at the end. So we have a case-based discussion followed by a panel with our experts. So over to Dr. Prabhash to get the evening started off. Prabhash, could you unmute yourself and start, please?
Good evening. Let me share my slides.
Prabhash, just introduce yourself in 2 lines or 3 lines and start your presentation.
The slides are visible?
Yes, very much so. Yes, yes.
Just a minute. Yeah, good evening, everybody. Thanks to organizers for asking me to present a case on empyema, pneumonia-related complications like that. Myself, Dr. Prabhash Prashungiri, I'm working as an Associate Professor of Pediatrics, as well as in charge of Pediatric Intensive Care Unit of Institute of Child Health in Kolkata. So in the next 20 minutes, I will try to present a case. Basically, it's a case of empyema. The headline of this case is known enemy with an unknown face. Why this tricky name? You will get the answer when you go through the case. So basically, this 2 year, 6 months old baby boy presented with a history of fever for 4 days, cough for 3 days, and respiratory distress for 1 day. So on an examinations on day 1, the day of admissions, he was a bit tachycardic, heart rate was 130 per minute, saturation was on the lower side, 92% at room air, 98% has fluid oxygen through a nasal prong. He was tachypneic, respiratory rate was 45 per minute, warm, well perfused, blood pressure was normal. There was a bit subcostal and substernal retractions, and auscultation revealed a decreased breath sound in the right side of the chest. So this could quite related to the clinical diagnosis of something happening with the chest, possibly a pneumonia, maybe a effusion like that. So first thing first, a chest X-ray was done on day 1. You can see the date is 12 Jan 2022. So this chest X-ray well revealed homogeneous opacity on the right upper lobe as well as the right middle lobe, and a bit lamellar effusions in the right pleural cavity. So the provisional diagnosis was made at a community-acquired pneumonia with a pneumonic effusions. He had been admitted in the pediatric ward as there was a minimal oxygen requirement. The initial investigations revealed a low hemoglobin, a sky-high CRP. Our CRP cutoff level is less than 5, with a hyponatremia and hypoalbuminemia. So already the capillary leak has started in on the day of admissions, and the day 4 of illness is the day one of admission. He started one ceftriaxone and ticoplanin as our hospital protocol, but there was increasing distress in the next 24 hours. He became continuously febrile and fever was not touching the baseline. So due to increasing respiratory distress and increasing the oxygen requirement, he has been shifted to the PICU on the next day, day 2 of admission. At PICU, he was tachycardic, tachypneic, saturation was hovering around 84 to 88% in room air, decreased breath sound on the right side, and put the child on HHFNC. And as a habit in our PICU, in any new patients, we did a focus, point of care, ultrasound of chest. So in focus, what he got, we got a moderately thick fluid in the pleural space. There's a few, or I can say moderate amount of septas were there, freely movable septas. There was early pleural defocations in the visceral pleura. There was a consolidation of the right upper and middle lobe. And we did a USG guided pleural tap, and a frank pus came out. The cellularity could not be done because of the frank pus. Glucose was not measurable, less than 5, and protein was 4.3 gram per DL. So till today, till that point of time, our diagnosis is a community-acquired pneumonia complicated by right-sided empyema. I'm sorry, I don't have the video of the ultrasound because I was not recording the video at that moment. our PSU protocol, according to the protocol, we have proceeded with the intercostal chest drainage, and USG guided intercostal chest drain was given on day 2 of hospital admission on 13th January. And significant amount of pus came out. And as there was free movable septus was there, we started giving some fibrinolytic agent. As urokinase is not available, altiplase is very much costly. We started on streptokinase. So our protocol is 15,000 intertestinal unit per kg 3 times per day into 3 days. So what we do, usually we dissolve the streptokinase total amount of streptokinase is 20 ml of normal saline. We push it in the intercostal chest drain, clamp it for 4 hours, then open it for 4 hours. So the dwell time is 4 hours and out time is 4 hours. So one cycle is 8 hours. So we usually do 3 cycles per day, total 9 cycles. Sometimes we do 6 cycles, sometimes we do 9 cycles. So in this version, we did 9 cycles. These are chest X-ray. You can see post-drain chest X-ray. The drain has been seen, and pleural space looked a bit clear after drainage of the fluid. So he did well in the post-drainage. Overall, the distress, fever and distress came down, and definitely the inflammatory markers decreased. You have seen that that hemoglobin came down to 6.7, but CRP had been significantly came down within 3 days from almost 350 to almost 50. Sodium has been increased. The baby had been settled. There was minimal oxygen requirement of 0.5 liter and was of IV fluid taking oral feeding. And we are considering whether we need to transfuse the patient as a 6.7 hemoglobin was there. But as he was hemodynamically stable and needing almost minimal oxygen, so we waited before transfusion. So on day 4 of illness, we got reports of cultures from pus culture and from blood cultures. So to our utter surprise, from both the places, we got streptopneumonia. So I think this is the first case when he got streptopneumonia from pleural space as well as from a blood culture. And you see that is a pan-sensitive streptococcus pneumoniae, definitely resistance to, even sensitive to penicillin G as well. As we started on ceftriaxone and teicoplanin, we did not change the medicines. Questions may arise why we wanted to continue with teicoplanin, but as the patient responded to both the drugs, we have continued both the drugs. On day 4 of illness, we're quite happy that at least we are not considering staph. We are getting streptopneumonia, pan-sensitive streptopneumonia. I think the patient will be doing well, maybe discharged within the next 3 or 4 days like that. But new fever spikes came on day 5 and day 6. Started looking sick again having tachycardia and tachypnea. At the time, clinical examination revealed decreased breath sound on the left side of the chest. A chest X has been done. You can see there are 2 predominant changes is there. I'm sorry, the quality of the X-ray is very bad because our digital system was not working at that moment. So in the left pleural space, you can see the haziness. So there are left pleural effusions, and the right side, you can see in the upper lobe, there are few small nematocysts are there, few breakdowns are there. So basically now we are facing a bilateral lymphoma with some evidence of necrosis in the right side. Again, we have done focus on the left side of the chest. It revealed a moderate pleural effusions, few movable septas were there, thick fluids were there, almost pus-like, and early pleural deposition was there. So left-sided and investigations are revealed on the same day. It revealed the secondary rise of the CRP. And in between that time, we have transfused the patient with a PRBC. We see that CRP again raised to 111.8 from 58.5. And there was even started on capillary leak. Patient became sick. Sodium came down again, tachycardic and tachypneic. So without any delay, we did left-sided ICT followed by streptokinase. You can see there are both side chest drains are there. Left-sided ICT has been given on day 7 and streptokinase given. Patient became afebrile again after 3 doses of streptokinase. Distress decreased and did well post streptokinase. And you can see on day 9, means after 3 doses of streptokinase, everything was perfect. Count has been came down from 31,000 to 22,000. CRP again came down from 111 to 16, and sodium again up. And at this moment, day 9 or day 10, he was afebrile for the last 48 hours. He was on oral feeding, off IV fluid, off oxygen, on room air, maintaining saturation around 93, 94. We are planning to ship the patient out of ICU. We started, we did a chest X-ray again at the same day because right-sided pleural drain was draining, but left-sided ICT was not draining and not moving as well. So you see that there are few persistent pleural disease on the right side, and if you appreciate well, there is a thin chink of free air inside the right pleural space. So again, we did a focus. This focus revealed there are remaining pleural diseases in there in the right side. Thick pleural materials are there in the right side, as well as pneumonia is there, consolidation is there in the right upper and lower middle lobe, and there are evidence of pneumothorax. And the right pleural drain was moving. So we are not removing the right pleural drain, but as there is nothing in the left pleural space, we are thinking about whether we should remove the left-sided drain or not. So left side removed on 24th of January, and IV antibiotic omitted after 14 days, 26th January, and oral antibiotic started, and patient has been shifted to pediatric ward. So again, we are after this X-ray, check X-ray, you can see on the just before removing the left-sided chest drain, and you can see that basically the right-sided parenchymal changes has been deteriorated. The pneumothorax has been went out, but almost right upper lobe and middle lobe consolidated, and there are few air inside the lung parenchyma in the few cavities are seen in the chest X-ray in the right lower lobe. Again, we did the chest ultrasound. It revealed, yes, definitely there are some cavities, but no cavities inside, no pus collection inside the pleural space. It is inside the lung parenchyma. At this moment on day 16, after stopping of antibiotic for 2 days, the slow grade fever started, but he was not sick, not tachypneic, no oxygen requirement, only low grade fever. So repeated the investigations are perfect, normal, CRP is negative. So at this moment, we are left with the two ICTs on left, on right. Left side almost normal, right side persistent pleural disease, persistent parenchymal disease, child otherwise looking well. We are dealing a sensitive organism, Streptococcus pneumoniae, 14 days IV antibiotic given, now on oral antibiotics. CRP stands still on 14. We have removed the left side of the chest drain. You have sent the repeated cultures. All the cultures are negative. No nosocomial. Again, you see in the right side that the further deterioration of the right side. There are many cavities seen in the right side. So now the concern is only on the right side. Left side is completely normal. So at this moment of time, there was the time that we need to go for a HRCT thorax. So question may be the other, why HRCT thorax was not done previously? Actually, in our PISO, we usually a bit hesitate to do CT thorax because CT scan is not available in our hospital. We need to send the patient outside, and most of the times we get almost all the equivalent informations on basically pleural informations by doing a lung sonography. So in this case, now the pleural spaces are a bit clear. Left-sided things has been over. On the right side, pleural spaces are a bit clear. A bit collection is there. We can see in the ultrasound, but on ultrasound, we see the lung parenchyma has some disturbances there. So when for a HRCT thorax, it revealed that mild residual right-sided empyema with ICD tube in situ, consolidation with cavitation in the right upper lobe, with mild consolidation in the right lower lobe, and multiple prominent mediastinal lymph nodes. You can see the cavities inside. You can see the chest tube inside. So there are lots of cavities. So at that moment, day 16 to day 19, one spike of fever, one or two spikes of fever, low grade, 100, 100.6 per day. The kid was otherwise doing well. No tachycardia, no tachypnea, in room air, on full oral feeding. ICD chest tube is there, tube is not moving. So what should he do? Even he clamped the tube, repeat the chest X-ray after 24 hours, there was no air collection in the pleural space. So what should be our take on at this moment? Should he take the ICT out, wait and watch for healing, or before go for a thoracotomy? We got similar two cases in the last 3 months. In all the two cases, we have proceeded for a conservative approach. We did nothing. We took the chest tube out, wait and watch, send the patient home, and ultimately the patient came back with some deteriorations, and ultimately we need to go for a thoracotomy. But this time, though the patient was clinically stable, there was minimal fever, antibiotic completed, CRP almost negative, patients looking well, but persistent right-sided parenchymal disease. Pleural disease is minimal. So basically, we went for a thoracotomy. And at the time of thoracotomy, the picture of the right lung was horrendous. You can see there are pus in the right upper lobe. The upper lobe has completely distracted. You can see there are some bubbling as seen. Whenever there is a bagging, there are some bubbling as seen. So you can see the air bubbles coming in. You can see the air bubbles. So what are the surgical note? The thick parietal peel like a cocoon, hindering the lung expansion. There is complete destruction of the upper lobe, look like ruptured lung abscess, with collection of the pus around the upper lobe. 2 bronchopolar fistula was found. The visceral peel was reasonably thin compared to the parietal one, and lung expanded well after decortication. So our decision of doing a thoracotomy in this patient was quite justified. This is the post-thoracotomy. We can see on day 20, the chest tube, 2 intercostal drain is given on the right side, lung is well expanded. And after 3 days of thoracotomy, the patient again started having fever, and you see the CRP again shooting up from 14 to 146. But we did not do anything. We already restarted ceftriaxone and teicoplanin from the day of thoracotomy. So we continued the same medications. All the cultures has been sent, came out to be negative. 1 test tube has been removed on day 25. You can see the lung well expanded. And then both test tube has been removed on day 28 and 29. You can see the lung well expanded. So first 14 days giving antibiotic. Then again, we have given total 10 days, starting from the day 20 to day 30. You can see the CRP came down. So this is a 3-day post-op, and day 29, again CRP came down. So today is day 30. Is being discharged today of all antibiotic for the last 2 days. A total 24 days. In between the time, he got 4 days of oral antibiotic. As we have given any antibiotic, we have not given any oral antibiotic at this moment. So what is concerning to this patient? Because I have seen lots of streptococcus pneumoniae that are presenting with a empyema, they are presenting with a lobar pneumonia, but I have never seen such type of refractory streptopneumonia when the blood culture and pus culture are showing pan-sensitive organism. And it's a bilateral empyema-thoracis in a case of streptococcus pneumoniae. And definitely the patient was not being vaccinated with any sorts of PCV. And to our experience in our PICU, for the last couple of years, we have seen that there's an increasing incidence of the empyema related to the previous years. And most of the times we did not get any organisms. If you get any organism, it is most likely Staphylococcus. I have seen only 2 or 3 cases of Streptococcus pneumoniae presenting with the empyema, not a pneumonic effusions. So searching of the literature, what we found that basically in the worldwide, the PICUs are telling that the incidence of empyema has been increased. It's a quite interesting article that's been published in Pediatrics, that empyema hospitalization increased in US children despite pneumococcal conjugate vaccines. So they're telling that whether you are using PCV7 or PCV13, the incidence of invasive pneumococcal disease has significantly decreased. Pneumococcal meningitis, pneumococcal septicemia, pneumococcal pneumonia, pneumococcal otitis media has decreased, but incidence of pneumococcal pneumonia followed by complicated by empyema has been increased. The same incidence has been found in Australia as well and globally. So this is the picture of the boy today. He's being discharged today after 30 days of hospitalizations, got total 24 days of IV antibiotic, ceftriaxone, teicoplanin, had a 2 ICD with fibrinolytic right side, left side, went a 1.5 hour long thoracotomy on the right side, and now he's doing well. Thank you.
Okay. What would be the opinion of the house? Do we come back to questions later? Should we start off with a panel, because there will be a lot of similar such questions and discussions amongst the experts on the panel. So I would suggest we move on to the panel discussion and then kind of come back with all our questions and answers. Is that agreeable with all of you who are present?
Yes. Yes.
Go on. Okay, so over to you, Dr. Kostov, because you'll be moderating the panel, and to Dr. Molnar and Dr. Shoni. Yes, Kostov, you want to get started off, please?
Yeah.
Kostov, there is a background noise from your I think from your laptop.
Yes,
Take off your
yes,
headphones and use the laptop microphone. It will be better.
Which one?
Take off your
Switch off the
headphones.
headphones.
Use the
Yeah.
laptop
হেডফোনটাকে
microphone. It
বন্ধ
will be
করে
better.
তুমি
Unplug your headphone.
ল্যাপটপের মাইক্রোফোনটা ইউজ করো।
তাতে আমার মনে হচ্ছে তো একটা প্রবলেম হবে মনে হচ্ছে।
না হবে না, তুই ওটাকে খুলে ফেল।
Let's see, I try.
হেডফোনটা আনপ্লাগ কর।
হ্যাঁ এক্স্যাক্টলি, হেডফোনটা আনপ্লাগ করো।
হেডফোন আনপ্লাগ হয়ে গেছে। It's okay. Is it audible?
হ্যাঁ
Yes,
অডিবল।
it's
অডিবল, একটা কন্টিনিউয়াস সাউন্ড আসছে।
মোবাইলটা ল্যাপটপের কাছে আছে?
না না, মোবাইল তো আলাদা করা আছে, মোবাইলে কোনো কানেকশন নেই।
একটা buzzing noise আসছে, একটা buzzing noise.
Let's try. ওই হিটিং এটা মনে হয় প্রবলেম করছে, হিটিং এর যেটা।
এটাকে তুই স্টার্ট কর।
Otherwise, he can start with this. He can start with this.
Let me start. Okay.
শোনা যাচ্ছে, তোর হেডফোন লাগবে না, তুই কি শুনতে পাচ্ছিস না?
আচ্ছা, now how it is? Is it audible quite nicely, or is it there is sound is still going on?
একটু কমেছে।
It's audible, but background noise ache ekটু. You can, I think, continue.
I think I just continue. Yeah. I think. Thank you, organizer, for giving me this opportunity to present in front of so august audience as well as seniors in the field of pediatric pulmonology, West Bengal chapter. So today's topic, as rightly said by Prabhash in his case, there are lots of issues that can comes up, and then obviously when we discuss this as panel discussion, those issues can be discussed also and possibly answered as well. I'm Dr. Kaustubh. Actually, I'm a pediatric intensivist in the hospital, Apollo Bengal Hospital, Kolkata, and to esteem panelists, is I think along with Prabhat, esteem panelists is there. One is Dr. Shami Harsha. He's a consultant pediatrician in Amni Hospital, Bellevue, as well as Columbia Asia, and Dr. Molnar Mukherjee is another consultant pediatrician in hospital, Highlands Hospital, Newtia Hospital, and Charn Hospital. So without wasting much time, I just share my screen and we'll go to that presentation. Hopefully my slides are visible. Is my slides visible?
Yes, that's fine, Costa. They're
Right.
visible.
Yes.
Yeah.
Okay, thank you very much. So when we are talking about empyema, as Dr. Provas has already mentioned, is also known as pyothorax or purulent pleuritis. So basically this word comes from a Greek word that is called empine, which means pus producing, that is suppurations. And as per definition, it's basically an accumulation of pus in the pleural cavity. And today's this panel discussion is basically aims at evaluating a patient with complicated pleural effusion and to know the current scientific evidences about the treatment of empyema, what is old and what is new evidences, and then discussing some controversial questions which might arise from this invasive management of empyema. To introduce that regarding empyema, you should know what is normal. So normal is basically a pleural space usually contains almost 0.3 ml per kg of fluid. So if it is a 10 kg child, it will be like 3 ml. If it is like 20 kg child, it is like 6 ml kind of fluid might be there in pleural space. And if we are talking about pleural fluid circulation and then in 24 hours, it will be around 100 ml of extra fluid that might present in pleural space. And there is a balance between secretion and absorption. And as we know that empyema is basically a complication of pneumonia. So if we go through the pathogenesis, it's basically 3 stages. One is exudative, so initial stage where for 1 to 3 days there's an exudate formation, and then there is, because of the inflammation going on in the pleural space, they try to confine, body try to confine, and then for 4 to 14 days there is a continuous process of fibrin or purulent stage is going on, and there's these fibrin productions are there. And ultimately, when that is extreme, after 14 days, they started that organizing stage. Either it recovers completely or it becomes organized to form peel formation. So that is after 14 days. When we are talking about clinical staging, so as clear, acute stage is the first 2 weeks of the onset, whereas chronic stage is going beyond that 2 weeks with the formation of thick peel. So I just want to share one pictorial presentation. So basically, if we are talking about this, sorry, talking about this X-ray, it suggests that there is some collection in the pleural space, that is in the right pleural, right hemithorax, and it involves less than 1/4 of the hemithorax. Then it is regarded as mild. Whereas when we are talking about moderate, that is, it should be more than 1/4 to less than half. So in this stage, it is regarded as moderate pleural effusion or moderate empyema. It is proved to be empyema. So moderate means it is the hemithorax, half of the less than half to 1/4 of the hemithorax is involved. So this is moderate, and if it is involving uh, more than half, then it is regarded as severe form of empyema. And if we convert it into CT scan, so this picture is clearly suggests that there is in the right lung there is a collection, which is a pleural effusion. Along with there is a lung which got collapsed because of this pleural effusion, and the rest of the lung is okay. And if you see the extra external part, that is the extra thoracic part, there is no collection, and this part are absolutely okay. So now to the our distinct panelists, we just try to find out what is the etiology of empyema. So Dr. Mallar, can you enlighten us on this portion, that what are the etiologies of empyema?
Yeah, very good evening to all the very good evening to all the audience members. I'm Dr. Malla Mukherjee. So without wasting any time, let me go through the etiology. When we consider the empyema, the first thing that comes in our mind is the lung disease. Mostly it is because of as a complication of pneumonia or lung abscess, parapneumotic effusion leading to empyema. So that is the first thing that always comes in our mind, the lung diseases. So other than those, there are certain other causes are there, like there may be saprophtenic abscess with ruptures, or post-traumatic or post-operative cases, or it's maybe blood spreading, or maybe iatrogenic. But the main concern of our discussion, or main topic of our discussion, will be around the lung disease, that is the pneumonia, parapneumotic effusion, followed by the empyema.
Absolutely. So this picture, actually, this etiological classification actually suggests that, as Dr. Mallar has correctly stated, that lung disease is the most common. But don't forget some other areas from where this abscess or this empyema can produce, like subclinic abscess, or it may be involving the extrathoracic part, sometimes even in the ribs, osteomyelitis also. So looking at the bacteriological etiology, Dr. Mallar, can you elaborate on this one?
Yes. So again, as Prabhash has mentioned, positive organism, so Streptococcus pneumoniae, it lists the top. Along with Streptococcus pneumoniae, there are other group A Streptococcus with Streptococcus miliary intermediates. Now the cases of the methicillin resistant Staphylococcus aureus, those are rising, those are on the rise along with MSSA. And other than those, there are some gram-negative organism, which may be the cases in case of infancies, like E. coli, Enterobacteriaceae, or Pseudomonas klebsiella. Those may be the hospital-acquired infection. Again, among the hospital-acquired infection, the MRSA also tops the list. So MRSA is emerging as one of the important pathological organisms, both in hospital-acquired as well as community-acquired. Lastly, not to mention the anaerobes, they are also forming an important group of the etiology for the development of the empyema.
Absolutely, absolutely. So what is can be added is that this portion we need to understand at this moment, that we are getting lots of cases of community acquired MRSA. and it's not less, it's almost like 10% of the total 25% of MRSA, which is almost community accord. And I think we all are agreed, particularly those who are working in the intensive care or who are associated with the pediatric pulmonology, possibly we are getting upsurge cases of community acquired MRSA, and this is really, really, I think, of need to be think of. And apart from that, as Dr. Provers has already mentioned about cause like Streptococcus pneumoniae is rising, but obviously with vaccination, this rise of empyema can be uh, possibly obstructed in the form, like, because whatever he shown is in his presentation that those papers are mostly based on the pre-PCB13, possibly PCB or pre-PCB10. It is mostly based on the PCB7. And as we have already discussed, so Streptococcus pneumoniae, there is a chance of increased resistance, particularly the 19A. We all know about these things. Then Staphylococcus, then the other organism, as Dr. Mulder has correctly stated. And this is also a slide which suggests that this 19A after post PCB7, there's upsurge of these strains, and then subsequently they are more resistant to the antibiotic also, and there is an upsurge of cases of empyema because of these complicated serotypes. So next comes that once we are talking about empyema, we usually go for diagnostic analysis of the pleural fluid. So, Dr. Muller, can you enlighten us on this?
Yeah.
So, pleural fluid.
We have collected it from the BTS guideline that we all know that whenever there's an opportunity, we will try to collect the pleural fluid during the maybe the placement of the drain. We can collect the routine what we do for the investigation like cell count, downstream bacterial culture. Not to forget that tuberculosis, though it's very unlikely in empyema, if there's a find that pleural lymphocytosis is there, then the consideration of the tuberculosis malignancy should be kept in mind. And if there's an indication that effusion is not secondary to infection, so consider an initial small volume diagnostic step for the cytological analysis. What I tried to mean is that empyema, mostly it means the bacterial etiology or as a result of the pneumonia, as a complication of pneumonia. But if there is a certain subtle clue for lymphocytosis and all this, the tuberculosis and malignancy should be kept into mind. Now, the earlier it was said that the pleural fluid, LDH, blood sugar, and these were of some importance. Now, the current guideline is saying that if there's a diagnostic dilemma only, or if you are trying to find the etiology other than bacterial etiology, other than pneumonia, like some collagen vascular disease, then the idea of doing rigorously the blood sugar, LDH, pH, all those should come into consideration.
Great.
That we have taken from the BTS guideline.
Yeah. So next we once we got a case of empyema, Dr. Shamik, what is your goal of treatment?
Yeah. So the goals of treatment is exactly what Prabhash was trying to say or trying to achieve with his case. That is number one, to treat the infection, to drain the purulent diffusion adequately and completely, and to ensure that there are no loculi left, because we saw what happens when one loculi of pus remains in the pleural cavity, and to allow re-expansion of the lung to fill the pleural space. We remember that Prabhash in his surgical notes had mentioned that there was such a thick pleural plating that it did not allow the lung expansion to occur. So basically, re-expansion of lung is all what we exactly need. We don't just need to drain out the pus. We want the functional unit of the thorax, that is the lungs, to expand and back to the normalcy. And obviously, by achieving the first three, we can eliminate complications and avoid chronicity. So these are the four basic goals of the treatment of a case of empyema. And just to add on to what Moller was saying, and these are the supportive management, but just to add on to what Moller was saying regarding the biochemical analysis of the pleural fluid. Now, this is from BTS guidelines, and BTS guidelines is excellent in making the thing simple. So what they have done, they have actually made the thing simple. Consider all empyema as parapneumonic effusion unless proven otherwise. The only other concern is malignancy. If there is malignancy, if you suspect malignancy, then do a small volume tap. Otherwise, proceed according to the plan for empyema. So that is what is the beauty of the BTS guidelines. So and then this is quite obvious that the supportive management like antipyretics and analgesics, particularly in presence of a chest drain, chest physiotherapy. Now this is something that we will come back later on. But as of now, chest physiotherapy is not particularly beneficial and should only be performed at certain stage of the treatment. Early mobilization obviously is important. Exercise is obviously important. Secondary thrombocytosis is common, and if you remember Prabhash's case, at the end of therapy, the platelet was about 6 lakhs, which kind of hovered around 3 lakhs to 4 lakhs, but at the end of therapy, it was 6 lakhs, which is another sign of recovery. So this is the after effects of successful treatment of empyema. And secondary scoliosis at times is common, but it's transient. It is only because of presence of chest drain and non-expansion of the lungs and the mechanical forces drawing the vertebral column and making the patient stooping forward. So these are transient things, and once the treatment has been taken care of, so these things would go. So I think these are the goals of therapy.
I think Shramik, you have well stated this. I think management-wise. So my next question is that what will be your first choice of antibiotic? How you plan antibiotic?
Right. So for any properly managed hospitalized care, nowadays the dictum is to look for the cultures and give antibiotics directed by the culture whenever it is possible. Well, we understand that in our country it is not always exactly possible, but whenever it is possible, it is always better to give antibiotics that are directed by the culture yield. Now, the commonest organisms of empyema are still Streptococcus pneumoniae and Staphylococcus and few gram-negative, and not to forget anaerobes. Therefore, for all community-acquired pneumonia and community-acquired pneumonia complicate giving rise to an empyema, the first line of IV treatment should be a third-generation cephalosporin or a second-generation cephalosporin like cefuroxime, and something to cover for the anaerobes. So metronidazole and ceftriaxone or cefuroxime plus metronidazole would be a decent choice. The other option is using a beta-lactam and beta-lactamase combination. Fluoroquinolones, though is mentioned over here, is not widely prescribed as the first line for empyema in different guidelines. I think this is there in the AACP guideline of America, but for BTS and American Association of Thoracic Surgeons, they recommend a second generation or third generation cephalosporin plus anaerobic coverage in the forms of metronidazole. Now, one thing is there, and anaerobic coverage is something that is important. And we need to give anaerobic coverage, but we must remember that anaerobes are fastidious organisms and they often yield a negative culture. So in our case discussion, we heard that few of the past cultures did not yield an organisms. Maybe there is a case to consider that those were probably organisms were probably anaerobes. And one thing is for certain that we need an antibiotic that needs good pleural space penetration. So penicillins, which is now universally resistant against Streptococcus pneumonia, but beta-lactamase combination, cephalosporins, and metronidazoles are the things of first line. Aminoglycosides are not to be used, and empirical hospital-acquired empyema treatment should also include MRSA and anaerobic bacteria. And now that we are seeing a surge of community-acquired MRSA, there is definitely a case for giving MRSA coverage till we find the culture for even community-acquired empyema.
Yeah, whenever the child is very sick, has to have add an coverage for MRSA. That is one thing we should keep in mind.
Okay, great, Ballan. So when you were talking about antibiotic, so question to Dr. Shramik Hachra, that how you decide about the duration of antibiotic, particularly in case of empyema?
So different guidelines differ a bit in terms of the total duration of the antibiotics, but one thing is for certain that first you wait for the response. The response is clinically given by lack of removal of the respiratory distress and more importantly defervescence. So you need to give at least 10 to 14 days of antibiotics after defervescence. which kind of gives rise to 2 weeks of antibiotic therapy. At times, and especially because in case of staphylococcus, we can go up to 4 weeks of antibiotic therapy. So the summary statement would be 2 to 4 weeks following defervescence. And it will obviously depend upon the sensitivity of the microorganisms, response to initial therapy, cessation of the output of the chest tube, how early or how late, the immune status of the host, especially if the host is immunocompromised or not, extent of the pulmonary pleural disease, and presence of other comorbid chronic pulmonary conditions. So that would be my answer.
Absolutely, absolutely well stated. So now to Molnar as well as Prabhash, how you approach particularly a case of impairment, and you all know that the duration of antibiotic, the antibiotic choice, already Dr. Shamik has quite extensively explained. But what? But all patients are not coming in the same patient. So how you approach a patient?
So let me go through this PITS guideline, PITS approach. First, we have to classify whether it's a small parapneumonic effusion or moderate to large. As Kosa was earlier explained, which is small and which is moderate to large. So if we are coming across with a small effusion, we have to treat conservatively with antibiotics only and clinical monitoring. If we see the improvement, we will continue this and continue antibiotic for at least 10 days after the disappearance of the fever. Now, after starting antibiotic in case of a small parapneumonic effusion, if there is no improvement or worsening of the clinical status within 24 to 48 hours, then we have to do a repeat chest X-ray. And if we see that effusion is larger, that is spreading towards the moderate to severe type of the empyema or parapneumonic effusion, then we have to manage accordingly. So please go through the next slide. I will tell you the approach.
Okay, so here one question to Molnar. So if you are getting something like this, say a mild case, and you want to do a diagnostic tap, and can you convert this diagnostic single tap into therapeutic tap and see whether there is any collection later on or not? So that is one of the mode of therapy. Do you consider that? You understand my question?
Yeah, I have understood. It's actually not given anywhere because therapeutic tap is of not that importance. Not that importance being given in the guidelines. So only for the therapeutic tap we are doing, because most of the times, if you having a small parapneumonic effusion, it will respond to antibiotic only. Most of the time, it goes away. Still, if we still want to find the etiology, we can go for an USG guided tap for the therapeutic purpose. But mostly in the most of the guidelines, it's not mentioned for doing therapeutic only.
Okay, I will again repost this question once we complete the topic discussion to all our esteemed pulmonologists in this forum, that I think they obviously experience such condition where they do a single tap and they just continue with the antibiotic. That diagnostic tap, they try to make it like therapeutic and then just continue with the antibiotic, and whether those child responded or whether there is any failure, that we will explain, we will discuss in the end of this panel discussion. So we'll move on to the next slide, that is what about if it is moderate or large effusion?
So then if we are considering, if we are coming across with a moderate to large, that is when the hemithorax is more than half or more than 1/4 to half or more than half is filled by the fluid, then first thing we have to do an ultrasonography. Here is giving us ultrasonography or CT scan, but it's better to go for the ultrasonography. Obviously, it is a non-radiating. So here what we can find a simple effusion which is non-loculated or a loculated effusion. Now, if we get a simple effusion, we have to do, because it is a moderate to large effusion, we have to do a ICT along with the IV antibiotics. So we have put a drain, we are continuing antibiotic. If we show the improvement, then gradually we will remove the drain and we will stop the antibiotic 10 days of the appearance of the fever, or maybe slightly more than that. Now, after putting the drain, if we are not seeing any response, if we are seeing the progressive worsening of the clinical clinical features, or repeat ultrasound showing is a reaccumulation of fluid, or loculation which was not earlier there, then we have to go for the certain other things. That is, only chest tube drainage and antibiotic won't serve the purpose in that case. So there are two proposals. One is saying that either you do the chest tube drainage and do the fibrinolytic therapy first on first go. Other proponents are saying on a first go, you go for the video-assisted thoracoscopic surgery. So there is a confusion in between these. We will be coming to that. Now, if we go for the fibrinolytic therapy with chest drainage, then we will observe the patient again. We will see the prognosis. We will see the improvement. If there is improvement, we will continue the same. If there is no improvement or persistent or progressive symptoms, then the PITS guideline is saying that the role of CT scan comes. What is the role of CT scan? By doing CT scan, we will come to know the underlying lung parenchyma. So what is the condition of the lung parenchyma? If we see that the parenchymal disease is mainly our concern, there is no obviously enhancement of the loculation or pleural fluid increment, then we will continue with this antibiotic only. If we see that there is a loculation has increased, there is a thick septa and all this, then we have to go for the VATS with debridement and chest tube drainage. This is we are calling from the PITS guideline, pediatric infectious disease.
Great. But having said that, here is one of my query is that if you are getting something like lung changes in the form of complicated pneumonia, either just like Probas's case, you are getting something like abscess or say necrotizing pneumonia. What is your mode of plan of management?
Yeah, if we are finding the abscess, necrotizing pneumonia, then in that case there is no point of continuing this fibrinolytic therapy only. Then we have to go for the open therapy, open surgery, either a form of the mini thoracotomy or decortication like this.
Okay. What about Shamik? Do you agree with this management?
Well,
Shamik?
I have few observations. The first one is regarding the approach to mild to moderate effusion, and there was a question raised on repeated tapping. So now the guidelines are quite clear that you do not do repeated tapping. You decide whether you want to tap or not. If you want to tap, you want to tap for once and all. Like as a decision making process. So put in an ICD if you think there is a moderate effusion, and just if you want to just tap for a diagnostic purpose only if you consider causes other than parapneumonic effusion as your primary cause of emphysema. Otherwise, go for an ICD or just give antibiotics for mild cases. Now, regarding this, yes, I agree with Molnar in totality that USG is the treatment modality, investigation modality of choice, and that as Prabhash was also telling about the focus. So every PICU should be equipped with a portable ultrasonography, and the residents and the intensivists managing those PICU must be well oriented with portable handheld ultrasonography and its uses. Now, this is one message that should go loud and clear. But regarding CT scan, yes, CT scan is not routinely recommended, as most of the guidelines say, only in complicated cases. One particular case in hand is a case like what Prabhash has encountered, or where there is an associated lung abscess, or where there is an associated necrotizing pneumonia. I think an early CT scan over here can actually help to better delineate the extent of the disease and to help us understand on deciding upon fibrinolysis alone vis-a-vis the early VATS or early thoracotomy. So this is what all I can.
Okay. Prabhash, do you agree with this management?
Partially. Basically, two things that there's no confusions about the management of mild effusions. Now, when I'm coming to the moderate to severe effusions, we need to look on 2 to 3 things. Number one, the duration of the illness. If the duration of the illness is usually more than 10 days, then it's unlikely to respond to conservative therapy like ICT plus minus fibrinolysis. We need to go beyond on that. That's our observations. Either go for VATS or thoracotomy. It's too old. If it's too old, 14 days, 15 days, 18 days, then even VATS is not effective. But if it's so much less, you cannot insert the VAT. Then you go for a thoracotomy. And depending upon the duration of the illness, the first ultrasound is very much important. What is we are doing in our ICU, that if you see on the ultrasound that fluid appears to be thick and there are movable septors are there. Septors are there, but septors are moving. Then you need something beyond ICT, means ICT plus fibrinolytic. But if you see that pleural space has been reduced, the fluid seems to be very much thick, fluids are not moving, and your septors are not moving, septors looks are very much thick, and it's loculated like a honeycombing appearance is there in the pleural space, then ICT and fibrinolytic will be not of any work. We need to go for VATS, provided the disease is around 10 days or 10 to 11 days of age. If it's beyond that, then even VATS is not working. Sometimes we send for a VATS and this VAT has been converted to a thoracotomy. For these cases, we have approached for a VATS with a consent, this VAT ultimately converted to be a thoracotomy. So the duration of the illness and the first sonography, the appearance of the and movability of the pleural space fluid, as well as the pattern and characteristic of the septa are very much important to decide whether we need to go for ICT plus fibrinolytic or VATS or thoracotomy. And if we are quite sure about empyema, not parapneumonic effusions, empyema is basically a severe form of parapneumonic effusions. If you consider about empyema, means pus in the pleural space, then you need to go beyond ICT, means at least ICT plus fibrinolytic.
Excellent. Thank you, Prabhash. But having said that, my question was clear cut. If there is involvement of the lung parenchyma in the form of necrotizing pneumonia or abscess, possibly BTS is clear about that you need to go for conservative mode compared to surgical intervention at the point go. Because what they are really worried about, that if you manipulate more the injured lungs, the chances of long-term complications are more compared to if you go conservatively. So BTS clear cut said that parenchymal abscess or necrosis should be managed non-operatively. If fibrinolytics or VATS is necessary due to lung this pleural involvement, it should be used. But having said that, caution should be taken with lung manipulation. So less lung manipulation is the bottom line. So moving on to other adjuncts, Mullar, anything you want to state?
Yeah, we have already mentioned those that USG is preferred over CT. CT reserved for the parenchymal complicated cases. And there's a thought that alternative is that the alternative chest tube placement for patients who are clinically stable is a trial of empirically selected IV antibiotic for 24 to 72 hours, who may be having a moderate pleural effusion, parapneumonic effusion, which is not too many days old. So there is a proposal that only IV antibiotics, giving IV antibiotics, trial of empirically selected for 24 to 72 hours. And as Prabhash has rightly said, that initial treatment is a complicated effusion. The pleural drainage with fibrinolytics or VATS is a reasonable first step, but mainly the choice is influenced by the available experts or cost consideration or patient preference and all these. So these are the things I would like to add along with the treatment approach. And once the antibiotics can be changed from the IV oral route if the child is sufferable for 2 to 5 days.
Excellent. Thank you, Mullah. So what about chest drain?
Chest drain, the earlier notion of the putting a large bore chest drain that has gone into vein. Now the small, less than 14 French pictal catheter-induced continuous drainage is being given all over the world. And clamping drain, that is a very important thing, that clamping drain for 1 hour after initial 10 ml per kg per drainage, or in larger children or adolescents, it should not be more than 1500 ml drainage in one setting, or not more than 500 ml per hour. Now, if you are seeing that there's a continuous bubbling drain, so there's a maybe possibility of the drain hole may come out of the visceral pleura, or there may be possibility of the tension pneumothorax. So if you are seeing there's a continuous bubbling drain, or there's a signs of deterioration, clinical deterioration, breathlessness, all these, So clamping should be avoided in that case. From there may be possibility of the tension pneumothorax. And removal once the clinical resolution is there, in 10 to 15 milliliter of drain for last 2 to 3 days, there is a removal of the chest drain is quite reasonable without any clamping.
So basically, when we are talking about continuous bubbling drains, the possibility of bronchopleural fistula should be kept in mind. And there you need not to go for any clamping, because unless if you do that, ultimately that can lead to tension pneumothorax. So what about fibrinolytic? We all know that we can use streptokinase, urokinase, and altiplase. Altiplase not available here, so we usually use streptokinase or urokinase. So what is your take on that, Dr. Muller?
Most of the time, the various RCT has shown that the fibrinolytics are quite effective. As far as the hospital duration is concerned, both fibrinolytic and VATS, they have given the similar result. The only thing is the cost. If the cost is higher in case of the VATS. Again, I want to emphasize one thing that okay, let me go to the next slide. If there is an adverse effects, yes. So surgical therapy. Sorry, Kosoda, I just go to a previous slide. I am telling. Now, what is the early and late VATS? If you do the VATS procedure early, yeah, proponents of the VATS. If the GA is for the chest drain and fibrinolytic therapy, then why not VATS? That question always comes into mind. So go for the early VATS, because it has been shown that if we do the VATS in the early procedure, then the hospital duration, staying duration automatically comes down. So only contraindication for the VATS is if it's not view accessible or if there's a thick pleural vein formation, then the VATS won't be that much of effective.
So early is the goal of the therapy. Early VATS is the goal of the therapy if possible.
Early VATS is the goal. As far as the hospital duration is concerned, both the fibrinolytic and VATS, they have the similar hospital duration. Only thing is the cost. And of course, the expert availability of the expert, patient preference, and all these things should be kept into mind.
Yeah. So one thing I just want to add on
Sorry,
is that,
can I just interrupt? We have to be wary about the time. It's already 9:30. So and there are a lot of questions pouring into the chat box.
We'll
so could we be a bit mindful of the time?
Yeah, definitely. So just to add on, there is a chances of fever when you are continuing with the fibrinolytic therapy. So you have to explain to the parents also regarding this one. Don't think it's a deterioration. So other surgical techniques, we are not going into the details, which are mini thoracotomy, which has been explained by Prabhash, as well as decortication if it is needed. But sometimes when we talk about pleural fluid classification, Shamik, we know about the Light's criteria. So we all know about how to differentiate between transudative and exudative. My question is that what about SAG? What do you mean by saying SAG?
Yeah, so again, basically SAG is serum acyclic albumin gradient, but you can use a serum effusion albumin gradient as well. So the major point in using SAG is at times Light's criteria may misidentify transudative effusion as an exudative one, as particularly in cardiac failure. So congestive cardiac failure is the commonest cause of transudative effusion, but at times that can be misdiagnosed as exudative effusion, and this is where SAG comes in. And there is also a case of doing a NT-proBNP level, which kind of clearly tells you that this is something of cardiac origin. So the SAG serum effusion albumin gradient of more than 1.2 is transudative, and protein gradient not more than 3.1 is again transudative. So this is the importance of SAG.
So your treatment goal, you said about chronicity and complications. Can you elaborate on something like this?
Yes. So see, just like look at this X-ray. So what we wanted to do, we wanted to prevent chronicity and we wanted to prevent complication in our approach to treat empyema. So this is a case of empyema after intercostal drainage, and you can see that there are so many bulli on both sides of the lung field. Someone may say that this is so many nematocells. Someone may say, no, this could be a hydrated disease. So there are these kind of pictures that can be seen. And even in Prabhash's case, we saw that there are nematocells on the right side of the lungs, even after insertion of the chest drain. So this is one complication. And then if we look into this, there is pus not only inside the pleural space, there is pus inside the subcutaneous space as well. So what is this? This is empyema necessitans. So what are the causes of chronicity? Is exactly what are the things that can go wrong during the management of empyema. So inadequate tube drainage, or faulty placement of the tube, or blockage of the tube, or displacement of the tube, that can give rise to chronicity. Presence of background TB or fungal infection a priori can give rise to chronicity. Obviously, the host factors like immunocompromised states and presence of foreign body within the pleural space, though very unlikely, is again a possibility of something that giving rise to chronicity. Now coming to complications. What could be the most important complication? Yes, it can rupture into the lungs, can go back. The infection came from the lung, but now there could be a backtracking resulting into the bronchopleural fistula. Again, in Probash's cases, there were two bronchopleural fistula. Persistent empyema frequently leads to bronchopleural fistula, spread to anteriorly into the subcutaneous tissue, giving rise to empyema necessitans, and obviously spread of infection through the blood, that is septicemia and shock, and a very high mortality.
Absolutely. So regarding some chronicity, if you are getting something like not responding, so you need to think some uncommon microbial causes like tuberculosis, some fungal infection, as Samik has already mentioned, and obviously don't forget hydrated disease also, because if you put a chest drain in hydrated disease, then it will be like a haywire. And I think Dr. Pallab Chatterjee well known about this tuberculosis empyema. Recently, we got one case which needed this bronchoscopy later and found to have endobronchial tuberculosis also. So I'm not going into these details. So this is something differential diagnosis. This milky white, we all know what is this. So diagnosis is basically a chylothorax. And mostly when we put our chest drain inadvertently, or if we are putting something like central line in the left side, possibility there is a chances of thoracic duct injury and lead to this type of presentation.
Yes. So I would just like to add on one thing in chylothorax. Chylothorax is another condition along with amyloidosis, which can give rise to either a transudate or an exudative kind of diffusion on tap. So this is again a situation where SAC comes into play to differentiate along with the physical
Absolutely.
appearance of yes.
Absolutely.
Could we wrap up the panel, please, as so that we could
within 5 minutes.
go to our question answers?
Yeah, 5
that would
minutes.
be nice.
So I think role of USG and CT already dealt by Dr. Molnar. So I'm not going into the details. So pleural lavage, local antibiotics doesn't improve our idea. And this is one thing we must discuss. So does the size matters? Obviously of the chest tube. So you see that the smaller car actually escaped. So when we are putting a chest tube, earlier notion, the old concept was to put a higher diameter chest tube like 32 French. But if you see the space, intercostal space, it's only 8.9 plus minus 1.4 millimeter. And now with the advent of this newer chest tube drainage like pigtail only on 8.3 French, which has an internal diameter of 2.8 millimeter, the results are comparable. So now we are going towards this pigtail rather than going for any large bore, wide bore chest tube drainage. So physiotherapy, Shamik, little bit points.
Yeah, in 10 seconds, the thing is physiotherapy, that right time is all that is important. When there is ICD in situ, we should not go for physiotherapy. Only after removal of ICD, we go for the physiotherapy and rehabilitative therapy. It is said to be decrease surgery and said to decrease the long-term pain and functional limitations for long, but now these concepts are gradually waning, or may I say going down the drain. So early lung exercise is more important than physiotherapy per se.
So in the very last slide, so prognosis wise, it's got complete recovery if you are managed properly, and there is no evidence that if it is antibiotic resistance, there's chances of poor outcome. It is not like that. And systemic review suggests that even in 3,418 patients with the mortality is very little, 3.3%, and while no death if it is like with fibrinolytic therapy, VADS or thoracotomy. And only 10% have residual symptoms. Mostly they do well in long term with mild and normal exercise tolerance. Thank you very much. Thank you panelists for elaborate discussion. Thank you Probhash. Thank you Pediatric Pulmonology WB's chapter for giving us opportunity. Now it is open for the discussion.
Thank you all. As all of us saw, Probhash kickstarted this wonderful teaching session with his exemplary case management and discussion. And there was a very interesting and detailed panel discussion. We have overshot the time, but it's a topic that kind of brings in a lot of discussion. I would now request Dr. Amita to moderate the question answer session. There have been a few questions typed into the chat box. So Amita, could you start, please? And once again, thank you. And I'm sorry if I kept kind of budging in at the end for the time, but there were time constraints, yes. But it was wonderful listening to all of you. Amita, please, could you moderate the question answers?
Yeah, so questions for Prabhash mainly, and I think other experts can help. Dr. Gautam Ghosh has asked why thoracotomy was delayed and what is the scope of thoracoscopy in empyema and what was the lung biopsy organism?
No, first, thoracotomy was not delayed because the child presented on the day 4 of the illness. And so we do not go to the thoracotomy firstly on the day 4 of the illness. All the times after giving ICD and streptokinase, the patient responded well. The child has been went for a thoracotomy basically due to parenchymal disease, not for a pleural disease. The classical book teaching is that for parenchymal illness, do not go for thoracotomy, wait and watch. And even after wait and watch, the child continuously having fever, the child was stable. But our decision of doing thoracotomy was perfect because was improper finding of lung infection. And that was not responding even after almost 2 weeks of IV antibiotics. Thoracotomy I think was not good, but done.
Muted.
I think about the biopsy specimen, it was sent almost 21 days of IV antibiotics, so no organism was got. Only the histopathology report was revealing as an empyema, and the patient responded. The pleural disease has been responded after 2 ICT and fibrinolytic. So thoracotomy was done for the parenchymal illness, but the classic book teaching is that we need to wait for a parenchymal illness before going for a thoracotomy, and it was finding was basically a lung upset, completely destruction of the upper lobe. And about the next question is thoracoscopy, I think.
Yeah, thoracoscopy. Yeah.
Yes, thoracoscopy VATS we can do at any moment, but as the patient responded to the pleural disease wise, so we did not go for a thoracoscopy because for a parenchymal illness, thoracoscopy is not very much effective. You need to go for a complete thoracotomy.
And another question, continuation by Dr. Gautam Ghosh. I think it was my doubt also why the empyema spread to the left side after a week, though the antibiotics were sensitive according to the cultures. And was it the ineffective antibiotic or was it a genetic defect like MSMD?
I already replied. MSMD is a very rare disease and it's very much rare.
But any congenital immunodeficiency, Prabhash, because these were sensitive antibiotics, and after giving that again the second.
I'll comment on the immunodeficiency. Definitely, if there's recurrent infections are there, then you need to consider about the immunodeficiency. You need to keep the patient on follow-up. Otherwise, the patient is 2.5 years old and there was no other infections at that moment. So unlikely to be a cell-mediated immunodeficiency because it was a bacterial infections and the patient was doing well up to 2.5 years of age without any previous history of infections. It's unlikely to be a Bruton's agramaglobulinemia because patient was doing perfectly up to 2.5 years of age. CVID, yes, CVID may be there, but we need to wait for sometimes for CVID. Unlikely to be a complement deficiency, unlikely to be a CGD because in the case of CGD, staph infection is more common. And MSMD is a very rare disease. It's usually presented with a repeated atypical mycobacteria as well as some salmonella typhi. Very rarely it can be streptoneumoni. So I think it's the patient is not fitting with the immunodeficiency, but definitely we need to closely follow up the patient in the future so that if there is any further severe life-threatening infections, then we need to definitely consider about immunodeficiency.
Amita, can I come in for a second?
Yes, sir, please.
To me, the possibility of having a left-sided infection may be twofold. One is aspirating the infected material. It was a necrotizing pneumonia, and there was a high virulence factor in the bacteria. And second, there was a septicemia also because the child was having a positive.
Exactly, it was a bloodstream infections. So only blood culture positive.
Two things can be considered for this left-sided infection. But I have a question to Prabhash. When the child presented to you as a community-acquired pneumonia, why you have offered teicoplanin upfront?
Teicoplanin, yeah.
With ceftriaxone.
Yes, the thing is that what we have seen that the community-acquired pneumonia, a typical lower pneumonia, But those who are looking a bit sick and without history of pneumococcal vaccine usually does not respond to ceftriaxone in our ICU data. Usually does not respond to ceftriaxone. I know that many of us can differ with that, but usually our ICU data, what we have seen, if you get a typical lower pneumonia, looks like a streptopneumonia clinically, without any history of pneumococcal vaccines, usually do not respond to ceftriaxone alone. And if the patient has a respiratory distress with oxygen requirement, we usually start on ceftriaxone plus teicoplanin. Actually, the incidence of DRSP is well established in the adults, but data from our country in the pediatric population is still less. Recently, a study has been shown that almost 10 to 12% of community acquired streptopneumonia are DRSP. If we go by the adult guidelines that the Harrison textbook mentioned 10 years ago, if you have a community acquired pneumonia in the adult, the first drug of choice, either of admitted patients, either a IV fluoroquinolones or a ceftriaxone plus macrolides or a ceftriaxone plus vancomycin or teicoplanin. So if it is followed in the adults, why not the pediatric population is there? I think more data will come up with the evidence that DRSP is not a myth. We are getting lots of cases of DRSP. Fortunately, this patient was sensitive to even penicillin G, that is very much rare nowadays.
Okay, can I come in for a moment, please, on
Yeah.
this? Yeah, so basically, it is well accepted that when you get a community acquired pneumonia and the child is sick, do consider staph as well, even if it's a lobar pneumonia. And we are getting emergence of community acquired pneumonia with staph where it is MRSA. So it makes a case for starting teicoplanin. Now, whether it's teicoplanin or vancomycin, teicoplanin has got a better patient compliance compared to vancomycin in terms of the adverse effect profile, in terms of the frequency of administration. So definitely a third generation cephalosporin and teicoplanin would be logical in our country. And but the thing, the question that was actually there was why teicoplanin was not changed after they got a culture of Streptococcus pneumonia. And I think Prabhash has already answered that since the patient had responded to teicoplanin and ceftriaxone combination, they did not want to disturb the milieu. So that is that kind of self-explanatory. And the thing is that whether we should also add metronidazole, because guidelines say something for the anaerobic coverage as well. So should you,
Shomik, in that case, any child who is getting admitted in a hospital with community acquired pneumonia, do you want to say that we should start teicoplanin or vancomycin with ceftriaxone? Which protocol you are? What is the source of your infection information?
No, this is not about any protocol. If the child is very sick, if there is parapneumonic effusion of moderate size, like Prabhash has got, is oxygen dependent, maybe a 6 to 7 days into
see the first X-ray, there was not much of effusion.
Yes, in the first.
Shubhashis,
Okay.
yeah, Shubhashis, if I can answer on behalf of
May I?
Yeah. Actually, I think you were at the back of his mind, he was thinking of a resistant staph also clinically. So, but since the child improved, he did, and even after he got the culture report, he took the call that he will not change it. And finally, I think that was what the intensivist mind was working in that way.
Okay. May I add something?
Yes, please go on.
Yeah, so I think from CMC Vellore, I think Dr. Balaraj already explained that this resistant type of Streptococcus pneumoniae, particularly in India, and there is 6-center study also they did, and subsequently they showed that there is not much existence of this resistant Streptococcus pneumoniae. So they are very well good with the ceftriaxone only. They respond well with ceftriaxone only. So that is from CMC Vellore. Having said that, there is a possibility of 10% chances are there that you can get something like resistant Streptococcus pneumonia, and there also the drug of choice will be vancomycin to add rather than teicoplanin directly. Maybe drug compliance, but no guidelines suggest that teicoplanin is superior to vancomycin. So I think for that time being, I'll go for vancomycin plus ceftriaxone if I am not clear about an organism. So possibly I will cover the staph as well as Streptococcus pneumoniae, which is resistant Streptococcus pneumoniae, but that chances are less compared to Staph aureus.
And Shomik, you said metronidazole. We usually do not add metronidazole in the first instance, like first line.
Yes, that is true. We do not add metronidazole, but then if you look into any of the guidelines, we have mentioned 3 guidelines like BTS, like AATS, and like ANCP. All of them have specifically mentioned coverage of anaerobes in your first line antibiotic choice. So everybody has said a second generation or third generation cephalosporin plus metronidazole. So and that was my question. How much those guidelines can be extrapolated to Indian data? Do we actually practice
If you
in
suspect
giving
that
metronidazole?
this empyema is arising out of aspiration pneumonia, like a cerebral palsy, or there is initially a parenchymal lung abscess, and that came out to be a case of pleural disease, or there is a concomitant liver abscess or a subdiaphragmatic abscess, so abscess anywhere in the body. So you need to cover about an anaerobe. I think at that point of time, my choice would have been clindamycin, because it is excellent drug. There's a good good anaerobic coverage, good streptococcal coverage, good MRSA, MSSA coverage.
Yes.
So I would prefer clindamycin along with ceftriaxone.
In this case, Prabha, I think you could have thought of clindamycin, because maybe this is a bacteria with Panton-Valentine leukocidin.
Yeah.
PVL.
PVL.
And also it is a case of necrotizing disease.
Necrotizing,
So
that's
and
right.
And pleural fistula there were.
Yes.
So, and it also fits into all the guidelines of covering the necessary organisms. So we do not go astray over there as well.
Shubhashish sir, do you want to explain that PVL for some of the audience? Just 1 minute. That PVL thing, I think for empyema would have been very good if it had.
This patient has been resistant to clindamycin actually.
Okay. So there is a comment from Apurva that TICO in lungs is same as Vanco.
Yes. No doubt about it. And if you compare the cost, ticoplanin is almost 40 to 50% cost reductions of vancomycins. It's less venotoxic, once daily dose. And invariably, if you give 10 vancomycin injections in our hospital scenario where nursing is that not much improved, then you almost get a thrombophlebitis. And you need to give very slow infections. The incidence of red man syndrome is not uncommon. And I found ticoplanin is almost equally effective and safe and vancomycin until and unless you are facing a meningitis. I think the role of ticoplanin in meningitis is still a bit doubtful, but few studies are coming in. Otherwise, Vanco is almost similar to Tico. Tico is similar to Vanco.
You are giving ceftriaxone that crosses the blood-brain barrier. So another question from Dr. Ilairaj was TB empyema, whether fibrinolytics or VATs.
TB empyema. I think for TB, TB is very rarely presenting with the empyema.
Very rarely causes empyema.
Until unless there is secondary infection.
I think why I put this slide of TB empyema is actually because of the chronicity, and you are not getting simple bacterial infection as pneumonic effusion kind of thing. And I think Pallabda is there. So we had a case recently. So TB empyema. Actually, TB empyema, and actually it proved to be an endobronchial tuberculosis when we did that fiber optic bronchoscopy. And it's a learning experience for everyone. And even that pleural fluid, we got this AB positivity. It was so positive.
I think most of the questions have been covered. If anybody has any other question.
Okay, so can I just take in the
can we just have a take-home message for the audience with regards to the duration of therapy? Just in one line, a take-home message. I'm not talking of 14 days and 24 days and things like that. Can we have a working take-home message with regards the duration of therapy in such a child that Prabhash had in his PICU?
I think guidelines is quite clear about the duration. So what they state is that once you start treatment, once the child is going to afebrile state, just go for another 10 days of antibiotic, whether IV or oral, doesn't matter.
I think 5 days after afebrile.
No, he said 10 to 14.
Total 10 days. And after 2 to 5 days, you can make it oral.
So 10 days after defervescence.
Correct.
10 days after defervescence. Yeah. Okay.
And obviously, adding to that, if your organism is something like staph aureus, you need to go for more, and you need to try to find out the focus, because it can be disseminated staph also. Because we got one case of empyema, staph empyema, where the focus is actually in the spinal, in the vertebra. And there, the treatment of duration is like 4 to 6 weeks.
Yeah. I think we've had a wonderful discussion, very fruitful, and a very, learning curves have been well amplified. Probably a time to ask the session to end. What do you say? Any other questions, Amita, in the chat box that has not been addressed to?
Jenny, can I come in for a second?
So
yes, please do.
Before one your talk, your words, I just give one point that once you are getting Streptococcus pneumoniae, try to find out the serotype, because that's the way we can prove that whether this is particularly a resistant serotype is growing or not. It's my humble request. So
where do we do that? Like, where are the serotype testings done?
Usually CMC fellow is doing that, so you have to contact with that and then subsequently send it to that sample to that
very
lab.
Difficult, yeah.
Impossible.
If you are getting the drug report, it's already sensitive to penicillin G, then why is doing serotype?
Okay, Paulo wanted to come in.
No. I think it was a wonderful discussion. Just two things I just had in my mind. One is VATS would have been a better choice rather than going for a thoracotomy, because much less this thing. So that is number one. Number two is I would really think that this child needs to be investigated for immunodeficiency, because such a community-acquired pneumonia with a strep pneumonia, which is sensitive to everything, leads to such a bad infection with a necrotizing pneumonia. We need to keep our antenna open, and we need to think that this child might come back with some sort of immune deficiency. So these children should be investigated actually,
Yeah.
So that's what I think.
Yeah.
Otherwise, fantastic case and fantastic presentation.
Yes.
Yeah. One more comment from Dr. Shomik Ghosh that serotype 3 in the pneumococcus has to be seriously considered in the vaccines. So because the serotype 3 usually leads to empyemas.
Just last comment from myself, that even if you are getting a community-acquired pneumonia in the chest X-ray, the first chest X-ray revealed a typical lobar pneumonia. You have given antibiotic, but even on that, if the patient is absolutely responsive to the antibiotic, gives one dose of ceftriaxone, patient responded well, don't do it again. But if you feel that patient is not responding within 1-2 days, then go for a lung sonography. Even if the first chest X-ray is not revealing anything, this is our hospital protocol that any pneumonia patient must have a lung sonography in the PICU and should have a lung sonography in every 48 hours if the patient is still febrile. If the patient is febrile after first dose of ceftriaxone after 48 hours, go for a lung sonography. And many of the cases we have seen, there is no stress of effusion in the first X-ray or first sonography, then gradually developed pleural effusion, pneumonic, empyema, thoracotomy, everything going on. So early pickup of pneumonia is very much effective. So your pneumonia is not improving. You are going on your antibiotics, ceftriaxone, ticaplanin, meropenem, colistin, but you are not diagnosing the empyema and draining it out. So this is the one message you should go, that use lung sonography as much as possible.
I think bottom line is always classical teaching is that once you are starting treatment of pneumonia, if the fever is persistent beyond 40 to 72 hours, think about complications. And just
Yeah, very good take-home message. Thank you. Yeah, it was wonderful. Wonderful. A round of applause to all. It was very well presented, very well discussed, and the questions brilliantly answered too. Thank you all.
Thank you very much
to all of you.
Thank you, everyone.
Thank you.
I think we all go back to our dinners now, right? And so we shall say good night. Yeah.
Bye, good night.
After our lungs is full, now the stomach should be full.
Absolutely. Otherwise, the brain won't work.
There is no